A very good morning to Indonesia. Thank you for the opportunity to share at the ASMIUA in this OSTEC collaborated workshop on the learning curve of laparoscopic urology surgery. This is a update of a talk that I gave several years ago, and it gives me great pleasure to firstly discuss about what is the learning curve, but more importantly, updates on the options of shortening the learning curve for both trainers, mentors, as well as trainees in a non-fellowship based, competency-based residency program. So what is really the learning curve? This was introduced by one of the Wright brothers and mainly in aircraft manufacturing. It relates to the time and cost of production of aircrafts. But in surgery, it is now taken to define as the number of procedures or the time that an average surgeon needs to be able to perform a procedure in a reasonable amount of time or experience and outcomes. And more, there is a graphic representation of this relationship between experience with a new surgery, as well as the outcome variable. So be it operation time, complication rate, or length of hospital stay. The learning curve experience is cumulative and leads to an improvement in performance. And the rate of learning is usually the quickest in the beginning, but stabilizes in the expert phase. So here we're going to see a couple of examples of these learning curves and how they determine the number of procedures required. And for laparoscopic donor nephrectomy, you can see the outcomes measured can be operating room, estimated blood loss, or intraoperative complications, operative time. And in this curve, you can see the initial steep rise of the curve and stabilizing in the operative timing. And this is the frequency of an operative time that is better than a third-year fellow. And things stabilize at about 28 cases. In terms of estimated blood loss, it also stabilizes at about between 20 to 30, slightly more than 30 cases. And here, in terms of intraoperative major complications, around these 24 cases. So this is an inverted curve. Of course, the higher it is, the better. So you get an idea of what the curve is in terms of number of cases or time versus an outcome. And in this, on the left side, laparoscopic partial nephrectomy, the trifecta outcomes here. And in these cases is in different eras of 25 cases with improvements with, of course, time. And in terms of the comparisons of laparoscopic and robotic cases, you can see here with laparoscopic being in blue and robotic in red, there is a trend towards reduction with improvement in number of cases, but it appears that the robotic we may require a fewer number of cases to achieve a better outcome. So what are the things we can do to improve mounting the learning curve for laparoscopic urology? And here you see Professor Halstead from Johns Hopkins University all the way back in 1890, where his mantra of see one, do one, teach one. Of course, he revolutionized surgical research, but in this day and age, surgical training has to evolve, and really there are many more tools that we can do or use to shorten the learning curve. You guys will know very well theoretical knowledge from books, courses such as the one today, as well as video on YouTube. However, there are many ways that we can do practical skills training before we actually arrive at the patient bedside. And I'm going to highlight some of these today. Certainly, we all know about basic laparoscopic skills in the dry lab, and there are many different surgical skills training, from stages in general surgery to AUA and EAU laparoscopic urology skills training. And these have the common validated set of dry lab exercises, which I think you will be practicing or training on some of them, including the familiar pack transfer, pattern cutting, and suturing and knot tying. The EAU E-Blast is probably one of the ones that has ASEAN or Asian countries more closely collaborated with than the AUA, and you can have more information on this on the website. Singapore Urology Association has collaborated with EAU or ESUT in laparoscopy training back in 2016, and we utilize the same E-Blast PAC training to facilitate this, and I'm sure EAU is very keen to collaborate with other ASEAN countries. There is no shortcut in their E-Blast certification, and for these tasks, as you can see on the left hand side, there are targeted times, so tests on how quick you are, as well as mistakes, so an evaluation on quality as well. The greater details can be found on their E-Blast website. And E-Blast certification is a benefit to all those residents who are keen to apply for EAU associated fellowships. You can of course do training at home, and here you can do an easy setup, buying equipment off Alibaba or Lazada, different shopping websites. These are some of my Vietnamese colleagues setting up their own training in the probably on-call room, and in the urology center at my hospital, the residents can train in laparoscopy as well as work in the urology center. So in their free time they can just pop over through the training room. So it is something that you can get your hands-on training. The OSTEC workshop of which you guys are attending is also a very useful way to get hands-on training and mount the curve, and this is what OSTEC is believing: technical professional proficiencies in urological skills. Look out for more workshops in the region, including animal work labs. So we have also done the work in the same task. We've done this called the FILS task, Fundamentals in Laparoscopy Surgery, and we try to correlate it to operative task, Objective Structured Assessment of Technical Skills, the OSATS, which is an evaluation of operative skills for porcine laparoscopy surgery. So we have so far looked at 128 participants in our various OSTEC workshops since over 5 years ago. And in this graph here on the top right, you can see that generally there is great subjective feedback on these different tasks in looking at content validity and different validation scores. They all score in excess of 4 out of 5. However, when we actually look at the correlation between OSATs, that means actual laparoscopic surgical experience, with each of the different tasks, from intracorporeal suturing to pack transfer, precision cutting time, cutting the circle, we do not find such a fantastic correlation. Certainly, there is a trend towards shorter time and better OSAT score. That means better surgical scores given by the trainers in the workshop, but these were all not statistically significant. and therefore it does perhaps show that just being good at dry lab skills does not necessarily mean that you will be good in the surgery, because dry lab skills is only one aspect of laparoscopic hands-on. Therefore, perhaps procedure-specific dry lab training is important. And we have at OSTEC worked on partial nephrectomy simulation or training models. And this actually is a very good basic simple training model where we use porcine kidneys, glue, super glue, and basically half the grape is plug conduit for you to practice a partial nephrectomy. We've not been able to fully validate this, and of course, because there is only a exophytic component, there is no intrarenal component in this, so it is less realistic. And of course, using animal models is less ideal. So here we can see a synthetic model that we have been using in our workshop, and it's called the X-Search, and it has a intra renal component with the tumor, and you can see that this tumor has been excised, and this is the closure of the renal parenchyma, and gives you an idea of the texture of the thing, and it has been worked quite well. Certainly, more and more complex training models, procedure-specific training models are arriving in the market, and really with 3D printing, this will be taken advanced into patient-specific training models in addition to procedure-specific. Certainly, it can even go one level higher, where you have a surgery-specific animal lab work. And here we published an article where we did a robotic kidney autotransplantation in a porcine model. This is to produce a procedure-specific training platform to facilitate robotic intracorporeal vascular anastomosis. And this is useful for training, not just in transplantation, but also vascular anastomosis. However, I think that the most important aspect of shortening the learning curve is to have a group proctor, preceptor, who provides education guidance, showing you the tips and tricks of laparoscopic surgery. This ensures safety, and as you want to start a new case, it will help to get the hospital support to get clearance when you start doing laparoscopy, and provides you with the confidence to kickstart your program. So what is a good proctor or preceptorship program? And here I will give credit to Professor Ra from Korea, who did a robotic proctorship for our institution on a robotic partial nephrectomy. And his program starts from pre-proctor, where there is an email communication to discuss the cases that we will operate, looking at the videos either on the YouTube or through emails of the surgical technique that he or we are going to use, and looking through the procedure card equipment preference discussion before the actual surgery itself. And here you can see that on the day of the proctorship, in addition to the actual preparation, we would have a lecture, rediscuss our cases, and one additional benefit is actually to review some of the laparoscopic cases, so that Dr. Ra could pitch what was our level. We were doing quite a lot of laparoscopic partial nephrectomy, and that allowed him to do primarily an advisory role in the surgery rather than a hands-on role. That to me is a model proctor, of which Dr. Ra has done a lot of in the region. And post-proctorship, there is a further briefing. So it is important to have a follow-up with your proctor to ensure that there is feedback on how to improve things. And based on this work, we have demonstrated that with the proctor and a team-based proctorship, you can transition from open or laparoscopic partial nephrectomy in a sustainable way, up to 2019, we were increasing our robotic partial nephrectomy cases. And despite the COVID, we have a pandemic, this has continued to increase 2021, and in this year so far, in the mid-year level, we've already hit our 2021 cases. So really this proctorship, I think, is crucial, be it laparoscopic or robotic surgery, for anyone to kickstart their program and to ensure sustainable growth for their outcomes. I have learned from this at my institution or wherever I go to the surgery, where you may start at the front doing the operation, but at some point you have to move to the back and be the assistant to facilitate a good proctorship, and therefore it applies for both robotic and laparoscopy. During the COVID period, in the OSTEC workshops, we have also tried to do tele proctoring, and this is the workshop with Dr. Kitinath in Thailand, and you can see that that's where we were trying to proctor over telementoring, and this of course needs some complicated setup with Zoom. And also different live station, and you will need help, and I think OSTEC has developed this very nicely, and probably is a way for the future. For the mentor, being able to convey your instructions over Zoom is also a very useful skill of relaying your instructions to teach. So that is another interesting aspect on telementoring. For those who are interested as a trainer, that technology enhanced surgical training certainly is going to be helpful to overcome the learning curve. And really, this has come to light. This is published in August 2022, easily available on the Royal College Surgeons of England workshop, and they highlighted the unmet need. Certainly the need of decreased exposure to operative time, the ability to do certain cases have been reduced due to the COVID-19 pandemic. And there are suggestions of different solutions as highlighted here to overcome this and increase technological exposure to training. Similarly, at our institution, and also highlighted by the same publishers of Royal College Surgeons, the virtual reality is increasingly used here in transplantation, where we visualize the donor kidney anatomy, and here you see my colleagues manipulating a reconstructed 3D image to help us plan for a complicated partial nephrectomy. This also is useful for education, training, and also planning for surgery, and I think also helps us to mount the learning curve. This is still developing in its infancy, but certainly watch this space, and I think technology will ultimately be able to help us move closer towards a quicker mounting of learning curve. So I think in conclusion, for the learning curve of laparoscopic urology surgery, I would suggest adopt a learning mindset versus a fixed mindset. Learning only in the operating theater is going to be a longer curve for you. You need to be able to use multiple avenues to mount that curve and to shorten it. Hard work, therefore, is important, but just drills on the dry lab alone may not be enough. A good proctor or preceptor may not be from the same institution, maybe other institution is quite useful. So being open to communicate is very important. Certainly consider equipment upgrades and use a technology enhanced learning, which may not need to be expensive. Since YouTube certainly has been a very good source of training even robotic videos can be very useful for laparoscopic surgeons to learn because of the clarity of the recording. So I hope that has given a thought to both trainers and trainees on the issue of learning curve in laparoscopic urology surgery. Thank you very much for your attention.